EMS clinicians commonly encounter patients who are in respiratory distress. Asthma or COPD exacerbation is often identified as the underlying cause. Good outcomes in these cases are dependent on timely and appropriate interventions. In the 2024 protocols, you will find changes to the asthma COPD algorithms that are intended to streamline treatment by eliminating some of the previously required medical consultations for paramedics. Let's take a look at how these changes will affect our treatment of both adult and pediatric patients. We'll start with the adult algorithm. You will find that the indications for treatment remain unchanged. Shortness of breath with wheezing or decreased air entry, presumed to be due to bronchospasm from reactive airway disease, asthma, or COPD. Signs of respiratory distress, which may include accessory muscle use, cyanosis or mottled skin, and nasal flaring or retractions. BLS treatment indications are also unchanged. Under ALS treatment, you will find several changes. We will start our treatment with administration of a combination of albuterol, 2.5 milligrams, mixed with ipratropium, 500 micrograms, nebulized. In the past, a medical consultation was required for all clinicians to give more than 2 doses of albuterol. Now, you will see that paramedics only may administer repeat nebulized albuterol as needed without medical consultation for recurrent or persistent symptoms. CRTs and EMTs, however, should continue to consult for patients who require more than 2 doses of albuterol. Although the consultation requirement for additional doses of albuterol has been removed, paramedics should closely reassess patients. Please recall that not all wheezing or shortness of breath is due to asthma or COPD. In other words, be careful not to get tunnel vision when treating patients with respiratory distress. The dosing of epinephrine has not been altered. For severe respiratory symptoms, administer epinephrine via autoinjector, 0.3 milligrams IM, or epinephrine, 1 milligram per ml concentration at 0.5 milligrams IM from a vial. This dose may be repeated every 5 minutes for a total of 3 doses, as needed for continued severe symptoms. After initiating bronchodilators or epinephrine, you should continue to establish IV or IO access for patients with moderate to severe respiratory distress. The algorithm continues to call for administration of dexamethasone 10 milligrams, but you will notice that IM administration was added as an option. Therefore, you may now administer dexamethasone IV, IM, or PO. For severe exacerbations, or patients whose condition deteriorates despite the treatments above, remember that you can administer nebulized treatments along with high flow oxygen, continuous positive airway pressure, CPAP, or via bag valve mask, BVM. The final change in the adult protocol is that for moderate to severe exacerbations, following administration of all other indicated medications in the algorithm, paramedics only may administer magnesium sulfate, 1 to 2 grams, mixed in 50 to 100 milliliters of an approved fluid, IV or IO over 10 to 20 minutes. A medical consultation is still required for CRTs to administer magnesium sulfate. Under medical consultation, you will continue to find that additional doses of ipratropium and epinephrine, either 1 milligram per ml or autoinjector, beyond doses listed, require a medical consultation for all ALS clinicians. Now let's turn to the pediatric protocol. As with adults, the pediatric indications and BLS treatment are unchanged. Scrolling down to the ALS portion of the algorithm, we find that the first dose of albuterol, with or without ipratropium, remains based on the patient's age. For infants less than 1 year of age, administer albuterol 1.25 milligrams nebulized. Ipratropium is contraindicated for this age group. For children who are at least 1 year old, but less than 2 years of age, administer albuterol 1.25 milligrams with ipratropium 250 micrograms nebulized. For patients 2 years old and older, administer albuterol 2.5 milligrams and ipratropium 500 micrograms nebulized. As with our adult patients, paramedics only may repeat albuterol as needed without medical consultation. CRTs and EMTs may repeat albuterol once without medical consultation. Similarly, the dosing of epinephrine, 1 milligram per ml, is the same as in the past. Patients less than 5 years of age should receive 0.15 milligrams IM in the lateral thigh. For those greater than 5 years old, administer 0.5 milligrams IM in the lateral thigh. Epinephrine dosing may be repeated every 5 minutes for a total of 3 doses as needed. Dexamethasone administration has been modified to include the option of IM administration, just as we saw in the adult algorithm. For moderate to severe exacerbations, consider the administration of dexamethasone 0.5 milligrams per kilogram, PO, IM, or IV, up to a maximum dose of 10 milligrams. Unlike the adult algorithm for moderate to severe exacerbations, administration of magnesium sulfate requires a medical consultation for all clinicians, including paramedics. Pediatric dosing of magnesium sulfate is 50 milligrams per kilogram, IV or IO, to a maximum of 2 grams mixed in 50 to 100 milliliters of an approved fluid. Remember, for children, administer a 20 milliliter per kilogram fluid bolus of lactated ringers with the magnesium sulfate to reduce the risk of hypotension. If we turn to the ALS pharmacology, these same changes are found on the albuterol, dexamethasone, and epinephrine pages. Scenario 1. You are treating a 57-year-old male patient with a history of COPD who is complaining of severe respiratory distress. He is sitting upright in a tripod position with rapid and labored breathing. On auscultation, you hear decreased air movement and tight inspiratory and expiratory wheezes in all fields. You notice his lips and fingers are cyanotic. His vital signs are BP 110/65, pulse 105, respiratory rate is 44, and his room air pulse ox reading is 84%. You have already placed the patient on high flow oxygen at 15 liters per minute and administered a combination of 2.5 milligrams of albuterol and 500 micrograms of ipratropium via nebulizer. The patient's pulse ox reading has improved slightly to 88%, but he continues to struggle and appears to be tiring. As a CRT, you may administer one additional dose of 2.5 milligrams albuterol without medical consultation, but any further doses will require consultation. A. True. B. False. Paramedics may administer additional doses of nebulized albuterol as needed without medical consultation. A. True. B. False. Your patient's symptoms persist despite administration of additional albuterol, epinephrine 0.5 milligrams IM, 10 milligrams dexamethasone IV, and placing the patient on CPAP. You are considering administration of magnesium sulfate. Which of the following is true? A. Both paramedics and CRTs must obtain a medical consultation prior to administering magnesium sulfate. B. Both paramedics and CRTs may administer magnesium sulfate without medical consultation following administration of all other medications in the algorithm. C. Only paramedics may administer magnesium sulfate without medical consultation following administration of all other medications in the algorithm. A medical consultation is required for CRTs. Scenario 2. You are en route to the ED with a 5-year-old female patient in severe respiratory distress. She has a history of asthma. She is sitting upright with rapid labored breathing, mottled skin, retractions, and nasal flaring. Her vital signs are BP 100/50, pulse of 120, respiratory rate of 60, and her pulse ox while on oxygen at 15 liters per minute via non-rebreather mask is 93%. On auscultation, she has diminished air movement in all fields, with inspiratory and expiratory wheezes throughout. As a paramedic, you have already administered high-flow oxygen, 2 doses of nebulized albuterol, the first combined with ipratropium, and 1 dose of 0.5 milligrams epinephrine IM. You are considering administering dexamethasone. The correct route of administration is A. PO, B. IM, C. IV. D. Any of the above choices are acceptable. Your patient's condition continues to deteriorate. Do additional doses of nebulized albuterol require a medical consultation? A. A medical consultation is required for all clinicians. B. CRTs are required to obtain a medical consultation, but paramedics may administer as needed without medical consultation. C. All ALS clinicians may administer additional doses as needed without medical consultation. You're considering administration of magnesium sulfate for this patient as you have given all of the other medications in the algorithm without significant improvement. All ALS clinicians are required to obtain a medical consultation prior to administering magnesium sulfate. A. True. B. False.